All right, good evening, everyone. Welcome to the SAGES webinar on the great debates for management of large paraesophageal hernias. My name is Ruchir Puri, and it's an honor to co-chair this webinar with Ivy Haskins. Um, for those of you who are not aware, I'm sure all of you are, I want to welcome you all to the SAGES webinar. SAGES is a great surgical organization with a bunch of members, close to 8,000 at this point, and we welcome all of you to take a close look at SAGES membership. The vision of SAGES is to reimagine surgical care for a healthier world. Our mission is to innovate, educate, and collaborate to improve patient outcomes, and we value inclusivity, innovation, service excellence, and global community. Um, a word about membership. It's special. There are several different categories of membership, from active to candidate membership. The candidate membership, which is for students, residents, and fellows, is $75 annually. As I mentioned, we have a large network of surgeons already. Members get an online subscription to surgical endoscopy, along with several grants and funding that's offered throughout the year. There are numerous courses, robotic courses, endoscopic courses that are offered at the meeting and at different venues across the country, which are great resource for all the trainees and even folks who have been out there in practice for a while. So there are numerous benefits to being a SAGES member. As I mentioned, there are different categories depending on your professional affiliations. Uh, this is the outline for the webinar today. Our first topic of debate is routine versus selective high resolution manometry in patients with large paraesophageal hernias. Dr. Priya Rajdev is going to present a case. And so I'm going to invite her to share her screen. I'm going to log out of the screen of my share. Just a few housekeeping tips. The chat has been disabled for this webinar, but there is a Q&A function available, so you can type your questions in the Q&A, and we will try to answer those questions in real time, and if not possible, then towards the end where we have some time for questions and a healthy discussion around these topics. And with that, I invite Priya to get started, and I look forward to a great debate. Thank you very much.
Thank you, Dr. Puri. My name is Priya Rajdev. I'm in Arizona, and I'm just going to jump right into our first topic, which is manometry and paraesophageal hernias. So I'll present a case from our institution. Very classic, 79-year-old gentleman with GERD. He had H. pylori, and back in 2023, he had been treated for H. pylori after having routine upper and lower endoscopy due to iron-deficient anemia. But over the course of those 2 years, he started having worsening substernal burning, epigastric pain, and some bloating. His PCP rechecked labs and also did a CT just to kind of figure out what was going on. Of note, he never complained of dysphagia, regurgitation, or any of the other secondary symptoms that you see there. The CT showed this. And you can see there were only axial views, unfortunately, but you can see that part of his stomach is up in his chest. He was restarted on a PPI and did not give him any relief. So he was sent back to GI. This is the rest of his history. His BMI was 38 at the time. He's a current nicotine user, but had no prior abdominal surgical history. And he lived independently after having been a widower some years ago. So GI scoped him and found this hernia. Therefore, he was referred to me due to his symptoms and due to the CT. So the first thing that we did was an upper GI. It's pretty standard for us in our practice, and these were some of the representative images. And we did do manometry, and this is what it showed. You can kind of see here that his lower esophageal sphincter tone, resting tone, is elevated, but otherwise he had normal swallows. And this is how they interpret, we have our GI doctors here interpret manometry, and this is how they interpreted it. So their concern was, of course, for EG junction outflow obstruction. And you can see here this paragraph that they write for patients who tend to have this finding without other clinical context. And so per their suggestions and per some of our practice here, we did actually send him for an endoflip. This was his endoscopy during endoflip, and you can see that the hernia is a little bit more obvious on this particular endoscopy. This is what they found. So overall, endoflip was normal. Our GI colleague did note one outlier, which you see in the second image here. But otherwise, this was not indicative of achalasia. So our pre-op management, we did optimize this patient in the following ways. He did start on Ozempic and did lose a significant amount of weight, but was also healthy lifestyle. He was able to achieve smoking cessation. I'm very proud of this patient. He's a great patient. And we did have him do cardiac workup, which was grossly normal. This is what it looked like intra-op. We proceeded with the following: robotic-assisted paraesophageal hernia repair. You can see some of the sac dissection on the top right. We close a hiatus with pledgets. These are phasics or P4HB pledgets, and did a toupee fundoplication. So then the question becomes this. As you can see from this case, we did manometry because it's our routine standard of practice. He did not have a complaint of dysphagia, just to refresh everyone's memories. And the manometry showed kind of what we thought it would show, which was EG junction outflow obstruction. And then I proceeded with an endoflip. So I welcome the debate to follow this.
All right. Thank you, Priya. Our next speaker is Dr. Alejandro Rodriguez, who is going to advocate for routine manometry on all patients that have large paraesophageal hernias. Alejandro, could you please share?
Yep, coming. Thank you again, everyone, for being online. Hopefully you can see my slides. So that was a great case. That was a great case, and I think it sets up this discussion pretty well. So I have no disclosures, and I will be talking about the before side of the debate for routine manometry in paraesophageal hernia repair. All right. So we know that in paraesophageal hernia repair, we have, in foregut surgery, we have all of these diagnostic modalities, and each one of them is telling a different story, right? Either the anatomy, the endoscopic view, the mucosa, the function, the physiology of this esophagus. A lot of this sort of helps us, all of these studies help us complement and really have a full picture of the esophagus that we want to be operating on. Do we have to take them all the time? Well, I'm pretty sure that a lot of you will agree that if we have good evidence of esophagitis, say esophagitis grade B, C, D, Barrett's esophagus, sometimes we can probably skip the pH. But what a lot of people are advocating for is skipping this other part of evaluating esophageal motor function. And I do not do this. Our case presenter does not do this, but some people do. Some people advocate for us to abandon manometries for paraesophageal hernia repairs. So why? Why would we skip it? There are a bunch of reasons. Each one will have, but I'll tell you a bit of the few that I've heard over the years. The first one is that it's technically difficult. And I'm sorry, I forgot to turn my video on. Oh, I can't actually turn my video on. So let me know when I can. So one thing I've heard is technically difficult, and I will agree that that it is. Sometimes, thank you. There we go. Sometimes it is technically difficult in a small hiatal or a normal esophagus. You will put the probe down. If you haven't seen how a manometry is done, it looks a lot like placing an NG tube. You'll ask the patient to swallow at the time you're throwing the catheter down, and you get no issues. So when you have a small hiatal or no hiatal hernia, the catheter will go down into the stomach. As we see here, the LES is clearly visible on the bottom of the screen, and we have a good chunk of stomach visible in the screen. In paraesophageal hernia repair, we often have distorted anatomy, and my catheter will get coiled up or will just bump against the esophagus. So it would be unwise for me to sort of try to keep poking if I'm feeling resistance. So this does happen, but I want to tell you, with patience, it's a little patience on your part or the technician's part and the patient's part. You can often get it through. So I will admit that it is somewhat technically difficult, but again, you can oftentimes get it done. Now, the next reason, unreliable. Why has it been called unreliable? As we just saw in our case presentation, a lot of the times people will say, oh, this is a paraesophageal hernia with EGJOO, esophageal gastric junction outflow obstruction. Now, why does this happen? Fortunately, this happens much less now. Before the current Chicago classification, before the advent of EndoFlip, if we saw this, that was it. This was a diagnosis, right? If we saw a non-relaxing LES, that's it. That's what we called it, EGJOO. And now we have to figure out what to do with your patient. Since the Chicago Type 4 classification, we know that it is not enough to do a manometry and call an EGJOO and EGJOO. We need to complement this with either an endoflip or a timed barium esophagram. So why does this happen? Well, it is a very, very simple technical factor. So this is a patient with a large hiatal or paraesophageal hernia, and you can see both high pressure zones, and I can see a high RP. This number should be under 15, but visually, this LES is relaxing. It has high-ish pressure, but then it relaxes and it contracts again. So this is relaxing. Why is my IRP then high if I do have a relaxing LES? Well, I want you to take a look at the bottom right screen where there's a marker that says gastric, and see that line that goes across the screen. I have my gastric marker set all the way down to the intra-abdominal stomach. So the software is taking that as a 0 and calculating everything else, all the LES pressures based on that. If I were to just move that marker to where the stomach really starts, well then, voila, my RRP is normal. So that's a very, very simple technical detail when someone is interpreting manometry. And it's just like anything else. If something doesn't look right, it probably isn't. If my IRP is high numerically, but graphically, I do see relaxation, then something is probably going on and I'm doing something wrong. So if you do manometries in your practice, or if you can review them, take a look to see if this is the case, and oftentimes you will find that it is. Now, other ways it is unreliable, because sometimes, like I showed, we can't always get to the LES. Sometimes I can't cross into the stomach because of the presence of hiatal hernia. So in this case, I can see the LES. I just couldn't get through to the stomach. But what can I see? I can see the motility of the whole esophageal body. I can see the proximal, mid, distal esophageal body. Sometimes I can't. Sometimes I'll stay above the LES, but I still have great data. I'm looking at the motility of the proximal, mid, and let's say the proximal part of the distal esophagus. I'm getting good data on that. Sometimes my catheter will double back, and this is what's called a butterfly image, but I'm essentially seeing the whole esophageal body. And sometimes I will find people who look like this, essentially an aperistaltic patient. You see some pressurization, but that is due to, if you look at it, it really looks like it is more concordant with the patient breathing. This is a phenomenon that is more often observed in obese patients. And sometimes you find this, again, this is a catheter that did not go all the way to the LES, but I am seeing waveforms that look a lot like panesophageal pressurization. Again, poor motility with something that looks like panesophageal pressurization. Now, would I rather know this beforehand? I mean, I would, right? So the last and third reason is just because, that's how we do it, and the data will back me up. I'm going to go through a couple studies which I expect my opponent will also highlight with a different view because there aren't that many of them. This is a study that looked at we have all retrospective studies, unfortunately, but this is a study that just looked at patients with hernia and no hernia, and they try to track out outcomes. And what they saw, well, patients, either independent of having a bad hernia or not, they have abnormal motility. And this patient specifically looked at omitting the manometry and going for upper GI instead, similar-ish outcomes. And we see this in this next study, where the post-op dysphagia rates are essentially the same, whether you got a manometry or not. So the data are what they are, and I would argue that they are imperfect. If you notice, all of these studies were done before the Chicago classification version 4, and so I have hypercontractile esophagus, EJJOO or not. I have sometimes poor motility, but these are all clumped together, and I don't think we should do that. I think we should look at patients with amotility, dysmotilic phenomenon like pan-esophageal pressurization, and then compare outcomes. Look at folks with ineffective esophageal motility, absent motility, then compare them to normal, and then look at outcomes, okay? So why do it? Again, I know some of you will not do a fundoplication at the end of this, but a lot of us will. And this is, again, just an anti-reflux procedure because we are taking everything down, because we want to strengthen our repair. We do not want our patient to have reflux. And so we know that for reflux, manometry is definitely indicated, right? So why are we skipping it? Again, why would we work up the patient at all? Well, we work up the patient for pre-op planning. We work up the patient for patient counseling. And we work it up, again, especially in esophageal disease, to get ahead of post-op issues. Now, this is a patient with post-op dysphagia, manometry that looks like type 2 achalasia. Whether this patient has true type 2 achalasia or not, I don't know. I do not have EndoFlip available. All I see is something that looks a lot like achalasia in a post-op patient who did not have a prior esophageal manometry. So that really gets you in a pickle. Can I have achalasia and paraesophageal hernias? It is rare. It is rare, but they do exist. This study found a small amount of hiatal hernias in patients with achalasia, so it is a rare thing. So I'll stop there and just say, just because you can skip it doesn't mean you should. Thanks.
All right. Thank you, Alex. Our next presenter is Dr. Nick Bildzukewicz, who is going to advocate for selective use of high-resolution manometry in patients with large paraesophageal hernias.
All right. Thank you, Ruchir.
Thanks, Nick.
So welcome, everyone. So I've got the task here of giving the article or the argument that selective use of manometry is best. But what I would argue is that this really should be called that high-resolution manometry is generally unnecessary. Now, Alejandro kind of commented on some of these things, and we will touch on some similar points. But as he mentioned, it is technically difficult, right? Both to not only perform the manometry, all right, but also to interpret the data. I think, Alejandro, you quoted this study, these guys out of Northwestern, so names that are familiar to all of us, Carrillis, Soper, Pandolfino. They looked at this study looking at patients who had large hiatal hernias, 90 of them, and they compared those to a large database, and they case matched it to 46 patients who had no hiatal hernia. You see here that they had trouble placing the catheter, right, in close to half the patients, 49%, because the catheter just in of itself would not traverse the diaphragm. So yes, with patients, you may be able to get it across the diaphragm. But even those patients who we suspect that may have trouble, we usually would schedule those for an endoscopy, right? So, but in their study, right, endoscopy was only successful, again, in less than half of the patients who they tried to place this endoscopically. And again, it's because the catheter frequently recoils into the stomach. So the first reason to generally consider not doing manometry is because it is technically difficult. right? Manometry is not always available, right? So if you practice in a small community hospital, maybe in a rural area, right, your patients may have to travel, several, 50 plus miles, several hours to even get manometry done. And I will tell you, in some facilities, it's only done as an outpatient. So currently, where I practice here, I don't have manometry available as an inpatient. It's only available at our outpatient endoscopy center. So consults, inpatient for volvulus and large hernias. It's sometimes impractical to actually get an esophageal manometry study. Manometry in of itself can also be expensive, right? This study that was published several years ago out of Canada showed that the equipment can cost over $70,000. The catheters themselves, right, are pretty expensive and are of limited use of about 300 studies. So based on this, as a second reason, manometry is not always available, again, depending on where you're at and your financial capabilities. So, but I think the big question is EM going to change your management? And I know Priya and Alejandro talked about some patients, and so, teaching residents and fellows, it's like you don't want to get tests unless it's going to really affect your management. So I think most of us, if you have a patient with a large paraesophageal hernia, do they have symptoms, right? So we can make arguments that if they don't have symptoms, that they can be carefully watched. But generally, these patients will have some degree of symptomatology, and the indication to fix a symptomatic paraesophageal hernia is the symptoms of it itself. So, and likewise, and Alejandro kind of touched on this, do you need a pH study, right, for these patients who have large symptomatic hernias? And the answer is no. So, in general, sometimes you'll have patients who will have chest x-rays that just show a large paraesophageal hernia. In my hands, I'm going to get a esophagram en route. I can scope them in the operating room prior to and during the surgery, and generally proceed with surgery without any untoward events. So, and I can also tell you that if you have a good video esophagram protocol, right, manometry is not going to alter your surgical management. So this is a study that I was part of when I was at USC, where we took over 400 patients who both had a complex video esophagram as well as high-resolution esophageal manometry. Of those patients who had a normal esophagram, you can see that only a small percentage, 2 patients, right, had both an abnormal DCI and percentile peristaltic swallows that was abnormal. Only 1 had both an abnormal DCI, and a abnormal mean wave amplitude. No patients had abnormal mean wave amplitudes and decreased peristalsis. None of the patients that we looked at in the study had any achalasia or absent contractility. We did have 1 patient who had IEM based on manometry. So looking at the patients who had an abnormal veg and manometry, so statistically significant differences. We detected 4 patients who had achalasia, 1 with absent contractility, and 22 who had IEM. So when you look at the data here, you get a negative predictive value of 99.6%, very high sensitivity. So generally, we concluded, and this was our kind of practice, that if your motility is fairly normal on a video esophagram, manometry is not going to change your surgical management or surgical plan going into repair. So, but some of you are out there, so what if I want to do a Nissen, right? So I can tell you Nissen is becoming less and less preferred of an operation. So there are several studies here that I'll share with you that Toupet is superior to Nissen. All right, so a meta-analysis, this was out of China back in 2015, but these authors concluded that, Toupet fundoplication had less dysphagia, less gas bloat, less inability to belch, and less reoperation for problems with dysphagia. Similarly, another meta-analysis published just a couple years ago showed that Nissen was equivalent to Toupet in controlling reflux and improving quality of life. But again, decreased complications less complications were seen with the Toupet. More recent meta-analysis, again, comparing Toupet to Nissen, favored Toupet for less dysphagia and gas bloats. Another randomized control study just published a couple years ago, all right, again, favored Toupet for improved reflux control, improved motility post-op, and less early obstructive symptoms. And then again, another meta-analysis here showing that Toupet is favored for durability and post-op dysphagia. So in my hands, Priya, in your case presentation, a 7-year-old male with a large paraesophageal hernia, they're not going to get a Nissen, they're going to get a Toupet. So I think moving forward with manometry is not going to change by surgical management. And clearly here, I think your EGJ alpha obstruction was secondary to the hernia. So I know Alejandro talked on this study. This is a letter to the editor that was written by Dr. Bonavina out of Italy and his group, but looking at perioperative value, and they really felt that preoperative manometry was unnecessary in patients with giant paraesophageal hernias, and that these generally get a toupee. So I think this is the better course of action to avoid manometry in these patients. And as most of you are probably aware, Stages was part of a multi-society consensus that published these guidelines 3 years ago, really looking at a key question whether partial versus complete fundoplication, meaning toupee versus nissen, is the better operation for adults with reflux disease. And after reviewing all the data, the authors here concluded that partial was favored for patients with reflux disease, at least in adults, generally because of fewer recurrences, fewer dysphagia, and a better side effect profile following the procedure. So again, showing that toupee is the favorite operation. So if you're doing manometry to get a better look at your motility, it's probably unnecessary in these patients with large hiatal hernias. But I'll end here. Is manometry patient friendly? Right, and studies have looked at this in the past, so you can see that close to half the patients who were surveyed in the study had mild to moderate symptoms following manometry. Right, so usually sores to the throat or nose lasting for hours, and in this study they showed that females had more complaints following the procedure. I will tell you, I've had patients tell me that this is the most unpleasant test they've ever had. Right, what could be more barbaric than shoving a catheter down their nose and asking them to swallow? Right, so. And patients can often have significant apprehension. So you look at this cartoon here, we'll do something called manometry, a test of your esophageal muscle contraction and relaxation. Doesn't sound relaxing. You may need an upper endoscopy as well. Oh man, none of this sounds fun. So patients can definitely be apprehensive, especially if they have any underlying psychiatric illness or anxiety. So let's look at some photos from the web. All right, so here's a gentleman showing up for his manometry study. Happy-go-lucky. He's got a little smile on his face. Well, here he is. Doesn't seem to be enjoying himself, right? With some lubricant placed down the nose, passing the catheter. Definitely no smile on this gentleman's face. Yes, gurgling salt water, and then having that catheter pulled out. So I ask all of you, how many of you would put your loved ones through this procedure? Not unless absolutely necessary. Right? What does AI say about this? Well, let's ask Google. Right, so I type in what do people say about having an esophageal manometry procedure. Right, they describe it as highly uncomfortable but brief. Clinical sources like Cleveland and Mayo state it's typically not painful, right? But all of the social media posts on Reddit and Facebook highlight intense sensations of gagging. Right, what about ChatGPT? Right, well, it's uncomfortable but usually manageable. Right, the worst part is the tube going through the nose and throat. It makes the eyes awkward, irritating, or gag-inducing. It makes the eyes water, right? Clearly, patients are not satisfied or happy with their manometry. And then what about social media? So I'll share with you some clips here that I found about patients' perceptions of manometry.
Nick, there's no audio, or at least I can't hear it.
You guys don't hear the audio?
No.
We're almost out of time, so it's probably okay.
So anyway, so I think in conclusion, there's one clear answer here that I think manometry is overall pretty useless for large paraesophageal hernias. I thank you for your time.
Thanks, Nick.
All right, that was a great first debate. We are going to segue into our next great debate, which will focus on paraesophageal hernia repair with versus without fundoplication. First up is Dr. Jonathan Levy. He is a minimally invasive foregut and general surgeon at the University of Michigan Health Sparrow Hospital in East Lansing, Michigan.
Sorry, I apologize. I was muted there. Thank you, Dr. Haskins, for having me, and really excited to be here. So I'm just going to go through a case report here that we had recently here. Sorry, I'm trying to. I'm going to get the slides actually up. So this patient presentation, this is somebody who came into my office about a month ago, 65-year-old female, past medical history of hypertension, diabetes, obstructive sleep apnea, osteopenia, IBS with constipation, a BMI of 31. Her past surgical history, she had a tubal ligation and a shoulder surgery in the past. Took metformin, atorvastatin, lisinopril, and carvedilol. But of note, her A1C was 5.6. She had no GERD symptoms. She had never really had any dysphagia, food sticking, stacking, no heartburn, no reflux, anything like that. But she did have this mild cough. It was a pretty persistent mild cough. It had gotten worse over the past 2 years, and ultimately she went and saw the ENT. ENT did a laryngoscopy, found maybe a little bit of erythema, really couldn't find another reason for it. So they referred to me for possible LPR. So of note, she had had a recent screening CT chest with a little bit of abdomen and pelvis as well for just pulmonary nodules. And so this is the third one she'd had. They'd made note of an incidentally found, you know, small to moderate hiatal hernia is what it was read. But as you can see here, it's a little bit more than a small hiatal hernia. About a third to half of the stomach is in the chest. Okay, so here's some more representative pictures for the residents. You can see sort of on all three views, coronal, axial, and sagittal, how large the paraesophageal hernia really was. And so, with that, with her symptoms, with a little bit of the erythema, we decided to do an EGD. So she had an EGD, showed LAA esophagitis. I measured an 8-centimeter type 3 paraesophageal hernia, which you can see both in the antegrade and retroflex views. I did biopsies, negative biopsies for H. pylori or Barrett's esophagus, both on cold forceps and Watts biopsy. She had a barium esophagram. These are two kind of representative samples of the esophagram. I didn't want to push you through the video. Showed mild cricopharyngeal dysmotility, a quote moderate paraesophageal hernia, and no delay of transit into the stomach, but very mild reflux noted. She went and got a manometry. This is actually not at our institution, but she got a manometry. So I'm sorry for the blurry photos, but ultimately normal motility per Chicago 4 classification. 100% normal DCI with mean of 1996. Medium IRP of 11 and no swallows over 20. And this is on the Maniscan software. And then it did note a large hiatal hernia visualized, which again is this red circle. So ultimately, we talked to the patient, and we knew that we were going to do a laparoscopic or robotic paraesophageal hernia repair, plus minus mesh, depending on how things went. But then the question for the panelists is, do we do a fundoplication or not?
Hi, everyone.
I'm going to introduce you real quick. Sorry, there's a delay on my end. So, arguing in favor of fundoplication will be Dr. David Spector. He is a metabolic and bariatric foregut surgeon at Brigham and Women's Faulkner Hospital in Jamaica Plain, Massachusetts. Thank you for being with us, Dr. Spector.
Hi, everyone. Thank you. This is great. I'm excited to join. Great case, Jonathan, and respect to my counterpart. She's a powerhouse, and thank God I can go first. Okay, so I have no disclosures. And so the question is, should we not funduplicate when we do a paraesophageal hernia repair? So just to frame the question, when the person is really sick and is trying to die and we have to get out, when there's like necrosis of the stomach, when you can't really do it that well, these are situations where it's not arguable we can not do a fundoplication. And it's pretty straightforward that when someone has preoperative assessment for reflux and they have reflux symptoms and they have reflux evidence that is objective, then you should funduplicate. That's not the debate. The debate is for the routine use of funduplication when this is not the case. And so historically, and when it's funny to say this historically, in the late 90s, early 2000s, there was a number of studies that basically from our like heavy hitters of our field, from the Demister group, showing that outcomes without fundoplication is not as good, and you should fundoplicate for reflux control. Also from the Swanson's group, the same kind of study, and a number of studies came out, and it became standard of care to do fundoplication when you do a paraesophageal hernia repair. You can cause bad reflux and so on. And so recently there's some studies that I'm sure my counterpart will discuss that bring that into question, and I'll try and dissuade you from that position. So just so we understand what we're talking about, what are the possible benefits of fundoplication? It can reduce reflux, obviously. It can help anchor the abdomen, the stomach, gastroesophageal junction in the abdomen, and reduce recurrence rates. And so, if this is like the story, and the disadvantages of fundoplication can cause dysphagia, is the concern. And we all know a wrap that's transdiaphragmatically herniated into the mediastinum, that's a big problem, and will be more likely to cause reoperation as compared to reflux, where you can just give medications for it. So a great study in 2013 asked this exact question. Retrospective, 22 no fundoplications, 130 fundoplications and paraesophageal hernia repairs. Of note, they all had, of the fundoplication, full wrap. And not surprisingly, the patients who were undergoing no fundoplication were almost 10 years older, sicker. Part of the reasons why people often wouldn't get a wrap. If you look at their preoperative symptoms, nothing really different, not significant. Of note, though, almost 65% of the patients who underwent a no fundoplication got a gastropexy, and this is relevant in the fact that now that we know that gastropexy done correctly can lower recurrence rates, it becomes a relevant factor in our interpreting the data. And so in the fundoplication group, only 15% of the patients had a pexy procedure done. Timing of the operation was very similar. Complications were much higher in the no fundoplication group, suggesting that that's why people didn't get fundoplicated. It's a retrospective study. Mean follow-up a bit over a year. Recurrence rates, very similar, a little lower actually in the fundoplication, but obviously not significant. But in the setting of 65% pexy in the no fundoplication group, this becomes a little bit more important. Dysphagia, a little bit more dysphagia in the fundoplication group. I'll remind you, everyone, this is a Nissen fundoplication in all these patients. Just as you heard a second ago, Nissens are maybe not the best choice for a paraesophageal hernia repair. Reflux, 5% after surgery versus 20% in the no fundoplication group. But more importantly, if you look at the preoperative reflux in patients, in the no fundoplication group, it went from 54 down to 20. And in the fundoplication group, the high 60s down to 5%. So much more robust result in that sense. And almost double the amount of patients needed to be on proton pump inhibitors after a no fundoplication paraesophageal hernia repair. So a great study that's really well put together. Was shown that what they did was they took 60 patients, and there are three parameters: reflux symptoms, esophagitis, and endoscopy, pH monitoring showing esophagitis. And if you had two of those, you were put into the group where you would get a fundoplication. If you had less than two, you were getting a paraesophageal hernia without a fundoplication. The follow-up was great. You can see all of them were followed. Almost all of them were followed from the symptoms perspective, and almost all of them had endoscopy and other things done at the year out. So this is a very strong study from this perspective. And at the end of the day, if you look, almost all the patients before surgery, see in the group that with fundoplication, almost all of them had reflux before surgery, went down to about 40% after the operation, versus 30% of patients who had no fundoplication had reflux, and that went up to about 50% up to almost 45% having reflux. So interestingly, when you look at dysphagia here in this group, very similar, about 8%, a bit more than 8% for both groups of dysphagia after surgery. No difference. And a very important parameter, I think, is if you look at the postoperative group without fundoplication, almost 30% of them had new onset of esophagitis. and almost 40% of them had new onset of pathological acid exposure. So a randomized control study in 2015, great study. What they basically did was they followed the patient at 3 months and 12 months, including endoscopy at 12 months. They took a bunch of patients, excluded some, got 40 patients and split into 2, 20 and 20 to fundoplication versus no fundoplication. The no fundoplication patients also got a PEXI. Here they almost all of them were, except for 2 that were lost of follow-up in the no PEXI group. Everyone was followed. You can see that if you look at the symptomatic outcome, the reflux syndrome score was significantly reduced in the fundoplication group. You can see here. And in the no fundoplication group, it reduced, but it wasn't significant and not as robust. And dysphagia, both were improvements in dysphagia after the fundoplication, no fundoplication, but no difference really was shown. Interesting, if you look at the esophagitis a year out, if you look at the preoperative patients who had no fundoplication group, 6 of them had esophagitis on endoscopy, and at the 12-month period after surgery, this increased to 8. Obviously, dramatic. And in the patients who had fundoplication, 7 of them had esophagitis, but this went down to 3, which is significant. So I'll summarize this with a study that was a meta-analysis done by my friend Ben Clapp. He put together basically a meta-analysis of all these studies and others. And if just to use it as a summarization, if you look at the after fundoplication, reflux was reduced as compared to no fundoplication, and and you can see that it almost reached significance, but it wasn't exact. But you can see it was for the fundoplication group. If you look at recurrence rates, also for better reduced recurrence rates after fundoplication, again, close to being significant, but not exact. If you look at the dysphagia, so a little bit increased. There was a bit of an increase in dysphagia after fundoplication as compared to no fundoplication. These patients, it was much less significant, but interestingly enough, if you take all the studies that were done in North America from this group, for this study, there was actually no difference in dysphagia. So I'm not sure how to interpret that, but, so I'll summarize and say that if you are doing a paraesophageal hernia, if it's elective or if it's an emergent operation, and if the patient's not too ill and they're not trying to die and you don't have to get out and you didn't have any necrosis of the stomach or tear the stomach or anything like that, and you know how to do it, I would say you need to fundoplicate.
Okay, thank you so much for the beginning of that discussion. So arguing against routine fundoplication will be Dr. Amber Shada. She is a minimally invasive and endoscopic foregut surgeon at the University of Wisconsin in Madison, Wisconsin. And I anticipate this will be a highly entertaining presentation.
Only if I can find my mute button. There we go. Okay. Thank you so much for the intro, and thanks Dr. Haskins and Puri for the opportunity to talk about the case against routine fundoplication during paraesophageal hernia repair. So my stance is that fundoplication is not wrong, but routine fundoplication is not evidence-based. And so the right approach is a selective fundoplication based on symptoms, objective reflux, and esophageal function. And I will try to explain to you why the patient that we were presented is not going to benefit from a fundoplication. So paraesophageal hernia is an anatomic problem which deserves an anatomic solution. This is a patient of mine, different patient than our patient at hand, but has a giant paraesophageal hernia with relative obstruction. He was eating his meals standing up over the sink just in case something were to come back up. But patients like him are everywhere with obstructive symptoms, postprandial pain, volvulus, anemia, even. I'll tell you more about that later. And the solution to that is to surgically move the stomach below the diaphragm, to excise the sac, to make sure that you have intra-abdominal esophagus, to close the hiatus, and then to prevent recurrence. And so the SAGES Guidelines Committee has looked at this. One of their key questions was, should fundoplication be performed in adult patients with symptomatic type 2, 3, or 4 hiatal hernia undergoing surgery? So they scoured the data. I have to admit that unlike my opponent, I did not go as far back into history to find data in support of my argument, maybe just a few years, so it's a little bit newer. But regardless, there's no difference in recurrence rate, whether you fundoplicate or not. There's no difference in reoperation rate. There's no difference in leak. There's no difference in quality of life measures. There is a difference in dysphagia. I won't spend too much time on that because that has already been explained by my opponent. Thank you. I will say that use of fundoplication during hiatal hernia repair should be tailored to individual patient need, desires, and presenting symptoms. And that's what the SAGES committee came away with. How about reflux? I think it's important to talk about reflux. I'll give you a slightly different paper. This is a really nicely done randomized controlled trial of 122 patients that looks at objective testing, pre and post. There are pH data, which I love. However, there are some problems. This randomized controlled trial, almost 75% of the patients enrolled in this are type 1 hiatal hernias. So not exactly our patient population. So let's not use those. Let's look only at the 40, right? That's our type 2s, 3s, and 4s, which makes it a bit of a smaller study, but that's okay. And now, just like my opponent said, this data is all about the Nissen. The patients who had a fundoplication got a Nissen fundoplication, which, as you know, is the best fundoplication we have to fix things like reflux and esophagitis. And the thing you also know is that the Nissen is dead, right? People do not use a Nissen when they do a paraesophageal hernia repair. If you do, though, let me know. Don't be offended. It's okay to use a Nissen, but it's just not really frequently done. So this randomized controlled trial, as promised, had amazing objective data. And you can see that the fundoplication group started with a Demeester score of 52. That has wild bad reflux. And it normalized. So their post-op pH test, Demeester was 7 or normal. Look at the no fundoplication group. They were just as bad. Their reflux average Demeester score was 52. And post-op went down to 12, also normal. But what about esophagitis, right? I did something a little different than my opponent, and I took out LA grade A esophagitis. Why? Because by the Lyon consensus, that's not esophagitis that even defines GERD. So this cohort in the fundoplication group had a rate of 18%. It did decrease to 3, and the no fundoplication group remained stable. So obviously this is not in support of no fundoplication in setting of esophagitis. I think you should consider fundoplication in the setting of esophagitis. So you should scope your patients intra-op. Here's another trial. Smaller in number, but this is true type 2s through 4s. My opponent already talked to you about this trial. The objective testing was done pre-operation, but not post. And as discussed, there is a cardiophrenic included in the no fundoplication group. Look at that thing. It's adorable, right? You see the cardia of the stomach is being sewn to the diaphragm. And I will argue, so this compared that cardiophrenic to a Nissen, and I would argue that this fundoplication of sorts on the left is very similar to the bespoke type of partial fundoplication that many people add, that I saw several people present at SAGES, for example. So it's comparing fundoplication to fundoplication. I digress. So the Demeester score was abnormal in both groups, but perhaps higher in the fundoplication group. Esophagitis, again, improved more in the fundoplication group. Hiatal hernia recurrence higher in the no fundoplication group here. So I would still consider fundoplication in the setting of esophagitis based on this trial that my opponent used. Okay, fundoplication, as you know, is not without side effects. I'm sure you are all picturing right now a patient that you have put a fundoplication into who has terrible dysphagia or gas bloat or inability to belch that never had those problems prior because their symptom was a paraesophageal hernia. And it's hard to do an operation on someone that does not meet their goals. That doesn't make anyone feel good. Fundoplication does not prevent recurrence. This is a great series out of Cleveland that looks at 1,155 patients. There's a higher rate of recurrence actually in the fundoplication group. Now we have some toupees coming in to be studied, by the way. It's about 3/4 Nissen and 1/4 toupee. The dysphagia rate, as we've talked about, was higher in the fundoplication group. Okay, now recurrence, the Achilles heel of paraesophageal hernia repair. This is a graph I made years ago that I love that looks at time on the x-axis and then recurrence rate on the y. And these are several randomized controlled trials looking at paraesophageal hernia repair. And you can see that over time, the bubbles are the size of the study. But given a long enough time, the recurrence rate goes up and up and up and perhaps approaches 100%. So fundoplications, though, when they're herniated, this data has been presented by my opponent, can create more problems than they ever solved, right? So if our recurrence rate is known to be high and climbing, then perhaps we should not put a bothersome, troublesome fundoplication in the way. So my stance remains that the data on routine fundoplication is not as robust as one would hope. So the right approach here is a selective fundoplication based on symptoms, objective reflux, and esophageal function. So let's talk here. I'm going to skip this briefly just to say that I would consider a fundoplication if there is objective reflux. I've talked about that at length. I would consider no fundoplication if you have obstructive symptoms, no reflux, or a high rate of post-op dysphagia. So back to our patient. She has Cameron erosions, no GERD, no dysphagia, normal motility, a giant paraesophageal hernia repair. That patient will get a paraesophageal hernia repair and no fundoplication. Thank you.
All right. Thank you, Amber. All right, moving on. This is great. So the next contentious topic we have to discuss is the mesh or no mesh. And once again, to present the case, we have Dr. Priya Rajdev from University of Arizona in Phoenix, who's going to talk about another patient with a large hernia.
All right, wonderful. So yeah, another patient of mine, 51-year-old lady who came to us with symptoms of reflux and had a known hiatal hernia. Oops. These are her symptoms. They were progressively worsening for 10 years. So you can see, in addition to substernal burning, she also more recently had some postprandial nausea, occasional dysphagia to pills, worse at nighttime, and PPIs, whether or not she was taking them regularly, couldn't quite get that out of her, but occasionally she got relief. She also had reactive airways disease, which had also been progressively worsening. She had seen a pulmonologist some years back and had an inhaler that she used occasionally and had gone to pulm rehab at some point. And she had previously been diagnosed with long COVID. These were her other medical issues. Notably, she's unhoused. So that does come into play for our patients, specifically in Phoenix. This is what her upper endoscopy looked like before she was referred to us. And you can very clearly see the hernia there. She was also noted to have some Barrett's on biopsy. And the first thing that we did is typical, is got our esophagram, and this is what it looked like. A nice oblique view there of this large type 3 paraesophageal hernia. We did do manometry, as I mentioned before, standard practice in our group. Also, she did have dysphagia, but it turns out, in spite of that, it was a normal study. Preoperatively, we did put her on a walking program. We do a lot of motivational interviewing here. We also ensured that she had safe post-op housing. And we do a lot of in-office communication. A lot of us draw pictures for our patients. And this is some of our handout, which I think matters for these patients who are just kind of our routine patients. So I figured I'd show you guys some of what we do. Intraoperatively, we ended up doing toupee for her because of her subjective symptoms of dysphagia. And you also just heard an excellent debate about the value of partial, no fundoplication, et cetera, et cetera. The The mesh that we use routinely here is a coated P4HB or bioresorbable. It is a biosynthetic mesh. It's bioresorbable. Goes away over 18 months. And we use that both for pledgets, as you can see here. That's how we were kind of trained. That's what we do here. And then we do a U-shaped mesh below the esophagus to reinforce that closure. We secured across the hiatus with a horizontal mattress stitch. So that's the short and sweet presentation, and I'm curious to hear what our experts think.
Thank you, Priya. So our next speaker is Dr. Tanuja Damani from NYU, who's going to advocate for the routine use of mesh in large paraesophageal hernias. Tanuja?
Great. Thanks, Ruchir. Priya, thanks for that case. Can you guys see my my deck?
Yep, we can see it.
Great. I just need to go into. All right, perfect. So this is an interesting topic. This may be the debate, because I think we can't debate this enough, because there is so much heterogeneity of data. Which mesh is used, how is it used, what's the configuration, what's the overlap, what's a recurrence. So I think we may never really have consensus on this, but I'm going to share a little bit of what we do and take it from there. It's kind of interesting talking about SAGES. BD actually, right when SAGES was happening, convened a hiatal hernia advisory group, and they had about 10 surgeons. And they didn't just get people who use Phasix ST like Priya does or I do. They had some who swore they would never place mesh, and some who used gore, and actually one who used permanent still. So I think it was a very interesting group, and again tells you that it's going to be very hard to get consensus. But I'm going to do my best about what my practice is and where that stems from. So I think this is pretty obvious from us, from primary closure versus mesh. There's data that is published on it that is obviously historical data that showed reduced recurrence rate with mesh. But to be clear, these were permanent meshes, PTFEs, polypropylenes, and polyesters. And it was a problem because even though the data showed reduced recurrence rate, we did see increased dysphagia, but more importantly, we saw those select cases that started popping up with erosion of this permanent mesh. Now we know we're in a highly dynamic area with the diaphragm and shortening and lengthening of the esophagus with each swallow are 10 to 15,000 times the diaphragm is moving. There's a lot of motion, and this kind of erosion was not like some of the other things we see. This led to major visceral resections, and of course this enthusiasm for permanent mesh for decreasing the recurrence really wore off pretty quickly after this, and actually has left many surgeons with PTSD. When they hear mesh, they really just think about permanent mesh and the bad things that happen to patients who needed multivisceral resections. So I caution you guys as residents and fellows that when you read literature, that you really read the fine print and not just the abstract. What was the population of patients that this mesh was being used on? Was it small sliding hernias? Was it true paraesophageals? Was it revisional? So really a hiatal hernia is a very loose term. We are focused here on paraesophageal hernias, and that's really what we want to think about. What kind of mesh was used? I alluded to the synthetics, but as you know, there's people who still use some biologics, and there's more than just listed here. And then, as was alluded to, the resorbable synthetics, which are really the BioA and Phasix ST meshes. So understand what mesh is used in these studies. How is it used? Sometimes people will create just pledgets of this and bring it together. Sometimes there's a little 2 centimeter strip of it placed posteriorly. And sometimes there is that mesh overlap that you just saw in the video, which is wide mesh overlap, which is what we aim for when we are doing these. And then again, when we talk about mesh, understand the recurrence. What is defined as recurrence in these papers? Is it any endoscopic or radiographic recurrence? Is it what is greater than 2 centimeters in craniocaudal dimension, which many people use radiographically? Or is it symptomatic recurrence? Because those things matter. So I think it's just as you look at it, just think about that. Biologic mesh, I think we can't say mesh and not really discuss this, even though really many of us realize that pure biologics are just a very expensive piece that lead to no real long-term benefit when we look at recurrence rates, which seems to be obviously one of our measures. So while the short-term data look good when these patients were followed out, and that's why sometimes these follow-up studies are very helpful, we found really no real difference in patients that have pure. But we did obviously see a much lower mesh-related complication rate, right? We didn't see those erosions and the fibrosis and the dysphagia that we worry about when we put mesh in this space. But here we are talking about the synthetic degradables. This is what I use in my space when I do paraesophageal hernias. And again, very clearly, these are paraesophageal hernias where more than a third of the stomach is herniated up. Now, remember the disease of paraesophageals. It is heavily, this patient is a little bit on the younger side, and I just operated on someone who was actually 41 this morning with a giant para. So those can happen, but the overwhelming majority of these are in the older population, where there's that stretching of or attenuation of the phrenoesophageal ligaments, the weakening of the diaphragm, less collagen, elastin. So when we are thinking about that, it's not bringing two robust pieces of crura together and saying, well, do we really need to put mesh? I think many of us would not use mesh in those situations, but this is a different subset of population where there is significant radial separation of the crura. There is significant attenuation or thinning of the crural muscle fibers. We know that. And there is the whole concept of, trying to reinforce, to allow modeling to happen and collagen deposition to happen. Now, clearly, we would never place inlay mesh, much like you guys wouldn't put in an ab wall. So we want to attain primary closure first. And then the question comes, can we place mesh that will do no harm, add minimal operative time, and potentially give us benefit, and that benefit being decreased recurrence rates in these patients. So that's where really this is my mesh of choice. As was alluded to, this is a polyhydroxybutyrate mesh. It is resorbable, although many of us who have been in at 22 months and 24 months have seen at least some stratus of it there. So, maybe it just gets incorporated, but, when you put the camera in, you can still see it. It handles really well, goes through an 8mm port and unravels. So, like I said, our first order of business is to make sure we're doing no harm. And that's where actually there is a fair bunch of data that has shown that we're not seeing those complications that we worry about in this. Now, there was one surgeon of the advisory board who mentioned about concern for erosion. And I will tell you that in all the discussions we had, these erosions where a little stratus mesh was seen, and these are really a handful of cases amongst the thousands we do, was managed endoscopically and did not require any surgery, and patient had no untoward consequences. But something to really think about as we think about using mesh, not always, not never, but with good judgment, selectively and liberally in some of these cases. So I think these studies really helped us say, well, we really are not in that space where we have to worry about mesh-related complications when we speak specifically about these kinds of bioresorbable meshes. And they are obviously, it's important to be thoughtful about the cost. We don't want to implant something that's going to be very expensive and it gives us no benefit. And that's where the cost of these is a lot more digestible than the pure biologics. So this is obviously some data that is published, one of the bigger studies, 500 patients. What's important about this study is it's all paraesophageal hernias. And what we are looking at really is when we look at primary suture closure versus phasics ST. What's also important is sometimes it's very difficult to make sense of studies when we look at recurrence rates because there have been relaxing incisions and there have been callus gastroplasties. And so is it really the mesh that decreased the recurrence, or was there other technical maneuvers that may have potentially decreased the other reasons for a recurrence? It's not just the radial aspect of it. It's also the axial tension. Here, it's by one surgeon, same technique, the same population. So it's a little bit more consistent data when we look at it. Of course, short term here is defined as less than 1 year. long-term is in that 1 to 2 year window. So clearly this patient population will be followed out for 5 years. But one thing this study did show is that we see less than, or basically 50% risk reduction in anatomic hernias, which were defined as more than 2 centimeters in the craniocaudal dimension. And then a 58% risk reduction for symptomatics. So again, this is important as well. This is what kind of I use when I think about this. Was a big, I think about 200 surgeons in Europe about consensus around where they would place it. So these are some of the things that I factor into. Consensus being defined as greater than 70%. When you have more than 50% intrathoracic stomach, you're seeing that crural separation, you're seeing the attenuated crura and for revisional surgery. So actually, I am not seeing my timer because I have my own screen here. So am I out of time?
Yeah, you're almost out of time, Tanuja.
We will skip the videos then. So this is important. So it's shown lower recurrence rates. We're doing no harm. Mesh-related complications with these kinds of synthetic resorbable meshes are over years now been studied, and we're not seeing that. And we are seeing data up to 2 years that's showing decreased recurrence rates, 50% risk reduction. And we hope that that's what we're going to continue to show longer term. So yes, I recommend use of this kind of mesh with a wide overlap in paraesophageal hernias where you have greater than a third of the stomach herniated. I will stop my share now.
All right. Thank you very much, Tanuja. Our next speaker who's going to speak against the routine use of mesh is Dr. Kristen Wong, who's MIS foregut surgeon from UAB. Kristen, go ahead.
Hello, everyone. Can you guys see my screen?
Yes.
Perfect. So thank you guys for having me. Thank you, Dr. Damani, for a good first opening argument. And I am now going to make the counter argument of no mesh. So my objectives today would be to go over the types of mesh used and why we should never use any of them, evidence to support why we shouldn't use them. And I'm not talking about single institution retrospective studies. I'm talking about meta-analyses, randomized controlled trials, and then make a few closing statements. So the first thing I'd like to point out is hiatal hernias and why they recur. So especially hiatal hernias, large ones have intrinsically high occurrence rates attributed to tension at the hiatus. And that's either axial along the length of the esophagus or laterally at the crural repair. So sources of tension at the hiatus include esophageal shortening, the natural pressure gradient between the abdomen and the thorax, attenuated crural tissue, as Dr. Damani implied, and the dynamic function of the diaphragm, which is in constant motion from respiration and also subject to sudden increase in tension from coughing, laughing, sneezing, or straining, such as the case presentation that we heard about before this. So mesh only addresses part of this problem, maybe. Maybe it addresses the attenuated crural tissue, but it certainly wouldn't address axial load caused by the patient that we heard's coughing. So I just wanted to point that out. So just to go over a few of the kinds of meshes, let's start with the permanent mesh. Use of permanent non-absorbable mesh is associated with an intense scarring response, and that's really its rationale for its use, but it can also cause a lot of problems. So mesh erosion, fistulization, esophageal stenosis, and the rate of complications from that ranges from 2 to 20% in the literature, and that can be catastrophic, requiring esophagectomy. This is a patient that I scoped a few months back who came from an outside hospital who had a circumferential PTFE mesh, and now it's eroded, and she has terrible dysphagia. She's likely going to need an esophagectomy. So that's why we no longer really are using permanent mesh at the hiatus. So what are our other options? And then we get into the absorbable mesh category. So on the left, you can see biologics. So that includes things like Surgisys or Stratus mesh that Dr. Damani mentioned. On the right, you see biosynthetic meshes, which is Phasix ST and BioA, which are the two most commonly used. And you can see the price range is anywhere from $400, $500 to upwards of a couple $1,000. And we're talking about a 7 by 10 centimeter small piece of mesh. So these are not cheap. So we really have to prove their effectiveness if we're going to spend this much money. So let's get into a little bit of the literature. This is one of the most cited studies, and Dr. Damani brought this up 654 times to be exact as of yesterday, according to Google Scholar, looking at mesh versus no mesh outcomes in paraesophageal hernia repair. So these are large paraesophageal hernias. It randomized patients to suture repair versus suture reinforced with small intestine submucosal mesh or Surgisys. And I want you guys to look at that Surgisys intestinal mucosa. That's so thin, that's not going to do anything probably. But what did they find? So looking at their outcomes, their first time point was at 6 months, and that was published in 2006, showed a quote unquote significant reduction in early recurrence, and the p-value was 0.04. And so that's, barely significant. They followed these patients out to 5 years, and lo and behold, there was no significant difference in radiologic recurrence. So what does it matter to prevent these early radiologic recurrences if the mesh group catches up in the end? So let's move on to more data. Here's a different study with 5-year follow-up. 126 patients randomized to suture repair or absorbable mesh or non-absorbable mesh. So comparing all categories. A recurrent hernia of any size was identified in 39% after suture repair, 56% in an absorbable mesh group, and 42% in the non-absorbable mesh group. And that was, again, no statistical significant difference. And in fact, the absorbable mesh was even higher than the suture repair alone. And not only were the recurrences the same at 5 years, but chest pain, diarrhea, gas bloat syndrome were more common after repair with absorbable mesh. I don't know how to explain this, but it's real. More side effects in the absorbable mesh category. And then finally, another study, if you haven't been convinced yet, here's a meta-analysis of 7 randomized controlled trials on mesh repair compared to no mesh in 2022. They looked at both short-term and long-term outcome, and they did a sub-analysis group based on type of mesh. So they looked at absorbable mesh and non-absorbable mesh. Short-term recurrence rates were no difference in terms of mesh versus no mesh. And even when you broke it down by absorbable versus non-absorbable, there was no difference in these short-term recurrence rates. What about the long-term recurrence rates? With a mean follow-up of 42 months, they also showed no difference in recurrence rates between mesh or no mesh repairs, including when analyzed by absorbable versus non-absorbable meshes. So I don't want to continue on because I think I've made my point, but I'd like to point out one last study. One group performed a systematic review to evaluate the safety, efficacy, and results of using a biosynthetic mesh to augment the hiatus. A total of 18 articles were included describing hiatal hernia repair using 3 different biosynthetic meshes. So that's Bio-A, Phasix ST, and polygalactin. There was significant heterogeneity and bias in evaluating the recurrence, lack of long-term follow-up, as well as lack of comparative groups. And it led the authors to say further trials with more power and long-term follow-up were needed before any conclusions can be made. And I point this out because this is Dr. Damani's paper. And so, our esteemed colleague also does not think that there's enough evidence to make any conclusions. So how many of us are actually putting in mesh? SAGES did a survey in 2012 of 2,500 surgeons performing hiatal hernia repairs and showed that only 25% of us are using mesh for most repairs, and the most common one being bioabsorbable mesh in 67% of those repairs. So if decreased recurrence in hiatal hernia repair is the holy grail of foregut surgery, if there was evidence to prove that mesh could do this, wouldn't every surgeon be using it? So I think I've kind of made my point with that. So in conclusion, meshes are expensive. There's no convincing evidence that it decreases recurrence, and there's possibly more side effects. And as a personal anecdote, it makes redo operations way more difficult. I just pulled some Phasix ST mesh off of a herniated stomach last week. So thank you.
All right. This has generated lots of discussion that hopefully we can get to during the Q&A. Lots of people have questions about mesh, which we knew would be a hot topic. So thank you, Tanuja and Kristen, for presenting. We are going to move along to our final great debate. It's going to focus on emergent versus elective repair of paraesophageal hernias that have a gastric volvulus. And I'll welcome Dr. Jonathan Levy back to do a case presentation.
Thank you again, Dr. Haskins, and I got my mute button working this time. So This is just a case, and yet another one about 2 weeks ago I saw. This is actually a 71-year-old female. She presented to the ED. I actually got a call from my partner about 5 o'clock at night about this patient. So past medical history of hypertension, COPD, CKD stage 3, AFib on Eliquis, history of GERD, and then unknown why, but quote, iron deficient anemia that she'd been dealing with for the past 2 years. She'd had an open appendectomy and an open right hemicolectomy in the past with ostomane reversal. Meds, she took Eliquis. She'd last taken her Eliquis about 24 hours prior to admission. She takes amlodipine, venlafaxine, lisinopril, and senna for chronic constipation. So she presented the ED with upper abdominal pain, nausea, and vomiting for 5 days. Vague symptoms, and ED was working her up. She had mild GERD at baseline. She takes an OTC famotidine sort of as needed. But she'd been having progressive intermittent dysphagia to solids and the liquids with some really severe chest pressure and chest tightness for the last 4 to 5 months. Been having nausea and vomiting about one to two times a week, and just kind of chalked it up to, whatever, she was getting over something. She had severe dyspnea on exertion that was worsening over the last 4 months, to the point where if she went anywhere, they had to basically park in the as close as humanly possible, because she could only walk about 20 steps or so without having to sit down. But I thought, okay, maybe it's COPD, so they were working that up. Of note, she had a known hiatal hernia, diagnosed at about 30 years old, but never really followed up for that. So her labs, when she came in, since she was in the ER, they of course worked her up. Blood pressure was pretty normal. Heart rate was low, elevated. Rest rate was 18 on 92% on 3-liter nasal cannula, and she normally is on room air. All of her labs effectively are normal on the right, but the only abnormal one in the hepatic panel was lipase of 105. So she was actually diagnosed with pancreatitis. And because ED is the ED, they got a CT scan. So here it is. So you start to see the stomach, large gastric bubble. Pancreas is actually pulled up a little bit into the chest, and you see organoaxial volvulus. So they called my partner, who then immediately called me. And again, just to show again for the residents, the three views of what we're looking at here. So ultimately, we're looking at a robotic or laparoscopic paraesophageal hernia repair. But the question is, do we do this emergently or do we do this electively? So I will stop sharing.
All right. Thank you so much for that case presentation. Arguing in favor of emergent repair will be Dr. Giovanni Dapri. He is the head of minimally invasive general and oncologic surgery at the University Hospital in Bergamo, Italy. There is a significant time difference, and Dr. Dapri is joining us live. So we just want to thank him for his participation despite the time difference.
Giovanni, can you hear us? Oh,
Dr. Dapri, you are muted still.
Yeah. So
hey, but
good
we can hear
morning.
you.
Yeah. So good morning, and thank you very much, Sages and Dr. Puri and Dr. Raskin, to invite me to give a presentation to this very nice webinar. And it is a pleasure. And I have no disclosure. I have no disclosure and about emergent paraesophageal hiatal hernia. When we look in literature, we have only case reports and no large series reported. Usually the treatment, especially in emergency, is doing by laparotomy and thoracotomy or both. And there is a quite high conversion rate when it is started by laparoscopy until 31%. There is also a quite high postoperative complication until 62%, and mortality reported until 20%. So when we okay. When we have a patient coming to emergency, clinically we have symptoms like vomiting, nausea, and sometimes we have also patient in sepsis. So in emergency, usually there are not too much exams to be done, mainly the esophagram, of course, but must be available, and overall the patient must be in good condition to do these exams. So usually the CT scan is performed, and it is helpful not only to understand the situation, but also to for the surgeon to choose the possibility to go to urgency or to wait for the day after. And so this is one of our cases that was treated here in Bergamo and in Italy. And so you see here the migration of quite entire stomach into the mediastinum with a partial volvulus. And in this type of patients, the attitude is, of course, if we can, is to place a nasogastric tube, but sometimes it's difficult because there is a volvulus and because also the patient is vomiting. And also we have the considering the hemodynamic stability of the patient. So if it is good, we can go to minimal invasive surgery. And usually there are different trocars to be placed. We use a safe opening abdomen in the umbilicus to introduce the optical system, and then like in a semi-arch line, the positioning of the different other trocars. So I show you a short video of emergent case arrived here in Italy, and you see that also with atraumatic graspers, it is very difficult sometimes to reduce the viscera herniated into the mediastinum. So in cases like this, where also the nasogastric tube cannot help, what we learned is to perform a small gastrotomy. Usually it is performed at the level of the antrum in order to deconflate and desufflate the stomach. In this way, the stomach can be reduced into the abdomen, and the nasogastric tube can be pushed down by the anesthesiologist in a good place and can be helped to empty completely the stomach. Of course, the gastrotomy is quite immediately closed to avoid spillage, and we can do it in different ways, and of course in uninterrupted suture, like here using absorbable suture. Then after, we have to be sure about the size of the site of the strangulated hernia. So we check where the tissue at the level of the fundus and the antrum. And so after that, we start with the classic operation doing usually in elective surgery. So we open the lesser curvature of the stomach, we try to identify the right crura, and we dissect the rest of the hiatus, reducing the hernia sac. After to have completely freed the right crura and also the left one, the hernia sac usually is removed, and so we go upper into the mediastinum looking for the hernia sac and completing the preparation of the crura. And of course, in this in this step, any orogastric bougie is inserted in order to have a better space and operative field. So the hernia sac is reduced into the stomach, and after that, it is removed. Sometimes, if it is small, it can be left in place. There is a problem of sometimes of seroma and hematoma, especially in at the level of the crura. So, if it is possible, it is quite mandatory to remove. And so after that, we continue with the mobilization of the rest of the inferior esophagus in order to have a better feed and a reduction into the abdomen. So usually more than 5 centimeter in height into the mediastinum is reached from the crura in order to have a complete reduction of the hiatal hernia. And so we continue with the closure of the crura with a figure of 8 suture. Non-absorbable suture are used like silk or Ticron. And then after, in order to avoid a dysphagia at the level of the crura, we perform an anterolateral suture to approximate the hiatus and close the defect. We don't use any mesh in emergency, and we perform, as already mentioned by the previous authors, a toupee, so 270-degree wrap to avoid any type of dysphagia, especially because this type of patients didn't have a preoperative manometry. So in order to avoid any problems, we perform a toupee with a fixation into the diaphragm. So this is the end of the procedure. And so since when I came back after 20 years in Belgium, I performed with my team here in Italy 68 giant hiatal hernia. And in total there was 26 giant in the 68 intrathoracic and general hiatal hernia. And in emergency, we performed 4 cases. And interesting, all the 4 patients were elderly if we consider a cutoff of 65 years old. There is a quite acceptable BMI, and 2 of them had a previous abdominal laparotomy. And operative time was between 1 hour and a half and 3 hours. All received a toupee fundoplication. In only one, it was needed a thoracic drain. We had, because we had the right pneumothorax, we didn't achieve any conversion to laparotomy so far, and we had 1 postoperative complication. The length of stay was 5 days, except one, which had the post-op complication with intensive care unit hospitalization. And during the follow-up, which is more than 1 year and a half, we didn't have any type of dysphagia. We didn't have any type of recurrence, and all the patient and reach, if you want, a solid diet after 1 month and a half. So, in conclusion, acute complicated hiatal hernia require urgent surgery. For open surgery remain a traditional approach, minimally invasive is feasible and safe. And in our experience, we didn't achieve so far conversion to open. controlled postoperative complication, acceptable hospital stay, no intra and post-op mortality, and satisfactory late functional results. So thank you for your attention.
Thank you so much for being here despite the time difference. All
Yeah.
right. So last but certainly not least, and wrapping up the last part of this great debate and arguing in favor of elective repair will be Dr. Caitlin Houghton. She is a minimally invasive foregut surgeon at Keck Medicine of USC in Los Angeles, California.
Sorry, guys, I want to go back, and there we go. Okay. Hi, thank you so much. What great discussions we've had so far, and so I'm excited to kind of round it out. And I'm going to debate that like the most of these patients should be done electively. So we've all seen these cases where you have the large hiatal hernia, you have they call volvulus. And I would say the patient that Dr. Levy presented, if we were doing our job, should have never presented to the ER in the first place. They'd known about that hernia for 30 years. I think I just want to go through a little bit of the historical perspective because I think it's shifting and we should be seeing less and less of these patients in the ER if we're doing our job right and repairing some of these elective hernias before they get to an obstructive point. So just to go back, in early 2000s, the annual probability of an emergent repair was about 1%, but most of these were being repaired open. And so there was a high morbidity and mortality for these patients. And so the recommendation was watchful waiting for everyone. And that's what's gotten us into this predicament of seeing so many patients coming through the ER that are older and having these huge gastric volvulus. Later in the late 2000s, 2010s, symptomatic patients were known to have a high risk of strangulation and ischemia. So the recommendation was, okay, all symptomatic patients need an operation. So maybe not watchful wait for everyone, but if you have symptoms, acid reflux, dysphagia, then you need an operation. In 2013, the SAGES guidelines showed that 14% per year chance that an asymptomatic hernia becomes symptomatic. So a pretty high chance that an asymptomatic hernia is going to convert to symptomatic. And there's about a 2% risk per year that the symptoms are going to be severe enough for an emergency. So if you take that, the SAGES guidelines are saying, elective repair of asymptomatic hernias can be done on a case-by-case basis. Now that we're doing more minimally invasive repairs, we know that 15 to 17% are going to convert, and the mortality and morbidity risk goes up if we do wait for these patients to be severe enough to be an emergency. So is it really that safe to do these electively before they get to the ER? Giant paraesophageal hernias, if we did a laparoscopic repair, you have excellent perioperative outcomes. Urgency of operation is a significant predictor of a mortality and morbidity. Elective repairs have about a 1% chance of mortality versus 8% chance in urgent cases. So we really want to prevent these from happening in the first place. And over a 75% of the stomach being intrathoracic in the intrathoracic position was an independent predictor of an urgent repair in the future. So giant paraesophageal hernia should be fixed electively. And I think because of that dogma early in the 2000s, we're still getting a lot of patients that were told that the hernia was there, but that they could wait. There's really nothing they needed to do about it, which I think leads us to this predicament. And really at this point shouldn't be the case. This is Dr. Damani's paper that was really looking at, is surgery safe enough in the modern era to operate on asymptomatic patients that are greater than 65? Most of the patients that were told to wait are older now. And so should we really be repairing these patients that come to us with these large intrathoracic stomachs if they're 65 to 80 years old? And this paper shows that mortality remains below 0.5% until about the age of 80. So if they're in the, 65 to 79, their mortality risk is pretty low, and we probably should be repairing those because we know if it becomes an emergency, mortality is 8.8% and major morbidity about 2%. So these patients are doing better in the age with minimally invasive techniques. So the risk watchful waiting is 5 to 17%. We should be fixing even these large hernias, even if they are asymptomatic, until about the age of 80, where we have to have a really good good discussion with the patient about risk and benefit. So with that being said, well, this patient is in the ER. We didn't get to them beforehand. They are in the ER. And we saw a really good example that Dr. Levy showed. But are we calling in the team in the middle of the night for these patients? And I'm just going to show a couple of CT scans. There's a large paraesophageal hernia with volvulus. Okay, pretty straightforward. Not a lot of fluid in there. Looks like, might have some nausea, vomiting, but no really concerning signs on the CT scan. Here we see some thickening of the stomach there. So this is, maybe a little bit more concerning. Maybe I should call in the OR team in the middle of the night for this patient. And then what about this one? This one, we're seeing even larger volvulus, lots of fluid in there, thin gastric wall. Maybe this patient needs to go to the OR. Or maybe not yet anyway. So how do we make that decision on if you can do an elective or need to go to the OR emergently? As we saw in the last presentation, even only 4% four of his 68 patients need an emergency repair. So probably a pretty low number are going to need that emergent repair. But we do have to take into consideration, do they have Bouchard's triad, vomiting, epigastric pain, inability to pass an NG tube? And if they do, our concern has to go up a little bit. Do they have abnormal vital signs, a white count, lactic acid creeping up, some tachycardia? Are they having other organ damage? And the patient we were presented didn't have any of these things, maybe a little tachycardia. How does the CT scan look? Okay, yes, there's gastric volvulus, but are there other signs? Are there ischemic changes? Is there perforation? Is there fluid? Are there any signs that this is the stomach is already compromised? And then do we have the ability to decompress? And I would say this is where we need to spend the most time for these patients that do have that are coming in with nausea, vomiting, dysphagia, asymptomatic gastric volvulus. NG tube and decompression is our best friend. We want to do this in as many patients as we can to help that decompress as soon as possible. Place it at the bedside. If you can decompress, great. That buys us time. And if we can't, we should move to endoscopic placement. If we haven't seen any of those concerning signs, if we can get an NG tube placed or do endoscopy to look at the gastric mucosa to ensure that there's no ischemic changes, we're in good shape and we can probably wait. And I would say, if we can do both of these things, get NG tube decompression and ensure that there's no mucosal ischemic changes on EGD, most of these patients should be non-emergent. We should not be calling the OR in the middle of the night. This paper was interesting. It was Dr. Dapri showed that there aren't a lot of multi-center studies. There's there's case reports, but this paper showed acute paraesophageal hernia with gastric volvulus and results of surgical treatment, a systemic review with meta-analysis. And what's really interesting about this paper is that less than 70% this isn't the really interesting part, but less than 70% with all three signs of Borcherdt's triad. So yes, we want concern, but they're not all going to show that triad. The really interesting part was that high volume centers operated emergently less often than lower medium volume centers. The more experienced centers did not operate emergently, and lower medium volume centers was an independent associated risk of 30 and 90-day mortality. So if you were in a low medium center, you go to the OR emergently, more likely to have a mortality. Whereas the high volume centers are waiting, they're decompressing, they're using GI colleagues to make sure there's no ischemic injury, and they're really evaluating the CT scan to make a decision. Now, that being said, I'm not going to show the video. That being said, I probably would do it in the same admission, depending on how bad the symptoms were after decompression, but it might not be emergent. I'm not going to show this video, but I did just post a video in light of this talk on the SAGE's foregut master collaboration on a really interesting redo. So if you want to see my technique, you can look at it for it there on YouTube. But we do want to, similarly to Dr. Dapri, get the hernias down. The one caveat I would say is that I'd start by getting the sac down, because I feel like if you get the sac kind of detached, the stomach is has more room and can come down without having to pull with so much tension. So in summary, don't rush to the OR. Decompression is the number one goal. Assess, obviously, for perforation, ischemia. You've got to look at the vitals. If there's any of those issues, that is the reason to go for an emergent repair. But most of these patients, you can convert an emergency to an semi-elective situation and reduce mortality and morbidity. And the high volume centers are doing that. Thank you.
All right, that wraps up our current great debates. I just have one slide to share. Oh, that's Ruchir's. Oh, there's multiple screen shares.
Oh,
Let's see if I can do it. Okay. You guys can see this slide? Yeah, okay. So this has been an outstanding discussion, and I want to thank all of our panelists for sharing their expertise. Lots of opinions in the foregut world. I think there's 12 of us. You might get 12 at least, minimum, different opinions. So we're happy to field some question and answers in this discussion part. I just wanted to virtually give each of our panelists a well-deserved round of applause. Thank you for sharing this data and also what you guys do. We do have a few minutes remaining for Q&A, and there are a few that Ruchir and I labeled to answer live. Before we transition, we'd like to thank everyone who joined us today as well. You will receive a post-webinar survey. Our goal is to meet the educational needs of both trainees and practicing surgeons. So we do truly appreciate your feedback so that we can make subsequent webinars tailored towards your educational needs. And finally, although most of us just saw each other at the SAGE's annual meeting, we would like to put an early plug in for the 2027 meeting. It will be held in Las Vegas this year or next year. And if you have never attended a SAGE's annual meeting, next year may be an excellent time for you to join us. So thank you all again. And Ruchir and I will get started fielding the Q&A. So there were a few questions. For anyone who wants to sort of talk about how they do it, there were several questions about how a gastropexy is performed. So if anyone wants to take a shot at that.
Sure. I'll say for the non-fundoplication pexy, I find the most effective way to go is to look at it as like closing the hiatus is one thing, and then pexing downstream or more caudal posterior second thing. And so I would like to say that my favorite way to do it is you take a nice bite of the junction between the esophagus and stomach, right between the two vaguses at the on the right side of it, and then you like suture to the just under the crewel's sutures. You just got to be careful. I take in like 2 bites to cruel sutures because I don't want to go too deep because there's a aorta right behind there. Two bites there. I have to say that also in sleeves, when I do a sleeve gastrectomy with a hiatal hernia repair, since I started doing that kind of apexia, I've like about 2.5 years, 150 cases. I haven't had a recurrence. Anyways, my recurrence rate before that was like in the 13%. So I'm a big fan of that.
Anyone else do it differently?
I can speak if so. The couple of things I think about Pexi that are important, which I think merit consideration. So, talking about what David was saying about the Pexi, if you have a large para, or back in the day for emergency cases, like, oh, you just go in and put it out and Pexi it, and you don't need to do a formal repair. And there's some truth to that, but the technical glitch is that every stomach has different adhesions to the sac. Every stomach is not just going to come down and say, hey, come down, it's going to come down. Some stomachs are going to come down easily, others will not. So just bear in mind for that Pexi for the incarcerated hernia. Now, that said, the other thing also, which is interesting, is for trainees, is that just like the human body, every stomach is not the same size. Some stomachs are smaller and some are larger. And so the ones with a huge fundus or that are really large, it's very easy to pexy them, anteriorly or enterolaterally to the diaphragm and anterior abdominal wall. And if you have a tiny stomach, though, that you can pexy anteriorly or superiorly, you cannot really pexy laterally, if that makes sense. And obviously, the left ventricle sits right there, so you have to be mindful of how deep a bite you take when you're trying to do an anterior or superior gastropexy. Obviously, laterally, if you have a big stomach, that's easy because you're away from the left ventricle then. And then to make it more complicated for myself and everybody listening, sometimes if I'm doing it just a pexy for a para, I'll use a permanent V-lock. And other times, if I'm more concerned about recurrence, I'll just use interrupted silks. So hopefully none of that made sense. Maybe some of it did, but anywho.
Anyone else want to comment, or should we move on to the next question? Okay, so there was another question about how to cut the mesh. Does anyone want to talk about what they do for mesh placement?
Yes, hi. Sorry, you may not be able to see me, but can you hear me?
Yes, we can hear you.
Perfect, perfect. So this is such an interesting debate as well, because we like to debate here with all aspects of mesh. So I think it's the mesh configuration. How do we cut it? When I use a 7 by 10 centimeter phase XST, I will place it in a U configuration. Obviously, the U is not in the center of the mesh because you have much less overlap on the right cruise because of the cava, and you want much more of that overlap in the left space. Now, again, I think many of you have heard about, most of these hiatal defects when we see on large paras end up being more D-shaped, where there's a lot of laxity on that left anterolateral side. So the mesh only will abut the edge. So it's important to plicate that and take away that gap before you overlap with the mesh. I will take that left side and tuck it behind the spleen, just because I just want that wide overlap posteriorly. Of course, make sure you get a good overlap and secure it with some interrupted stitches. Now, there is different configurations. There is a reverse C configuration of the mesh. Clearly, the important thing to remember in this space, mesh should never be circumferential. So you have to make sure when you do the reverse C, the opening is on the right cruise side. And the thinking behind that reverse C configuration is most of those recurrences happen in that 12 o'clock to 4 o'clock left anterolateral kind of position. So maybe should we be looking at overlapping that area better? And then, of course, as you've read Krista Cohen's paper, he talks about a sunburst configuration. So I think it's really, again, coming down to a lot of dealer's choice. You're seeing at the hiatus, how things look. If it's a redo case,
Tanuja, we lost you. I think you're muted.
sorry, I think I wrapped up. I don't know where I lost, but I think can you hear me?
Yes.
Yes.
Yeah. I don't know where you lost me, but I think I was just saying that some of the configuration is based on the intraoperative determination of how the hiatus looks as well.
So another question sort of that came up that was part of this was why most of us do a U-shaped mesh when most recurrences are anterior and lateral. Does anyone want to talk about their mesh technique and why they do a U-shape?
I'll
I
toss
can.
in 2 cents
Oh yeah,
here.
go ahead.
Our U-shaped mesh is probably has two different aspects of reasoning behind it. Yes, to reinforce that posterior closure, but we're almost thinking of it as like an external vise, as opposed to purely mesh overlap. So the thought with us putting this across the hiatus and then securing it with a horizontal mattress across, it took me a while to understand, the logic behind it, but we're sort of trying to offload that hypothetical tension from that closure from side to side. And so almost like if you've ever done woodworking, if you have two pieces of wood that you've glued together, you put an external vise around it until that glue has time to heal. So that's why we use an U-shaped mesh. But of course, I agree with Tanuja. If we could have some kind of, smart intraoperative, potentially AI way of understanding, hey, this mesh is shaped like this defect is shaped like XYZ. Maybe you should configure your mesh in a slightly different way. Maybe that's the future.
I think this question is really hard because because traditionally we always did U shape, and then now noticing that those recurrences are in that upper area and there's laxity there. I think for me, I'm mostly posterior U shape. But if I put plicating stitches in that left lateral, if there is laxity there and I'm putting some sutures in that upper left cruce, then I'm going to switch it to reverse C. But in both cases, I'm covering both areas. So I'm making sure that if I'm doing a reverse C, that C comes all the way across and is covering the posterior. So you're giving that kind of vice tension there, but then more overlap on that upper area where it might separate because it was lax to begin with. Whereas if I have straight up and down pillars that are like really robust in a primary case, I'm likely going to just keep it in the reverse C, making sure that left-sided curl pillar part goes up and extends up to at least extend to that area where you might see the recurrence. So either way, I feel like I'm covering both areas.
So I have a question for all of you. Do most of you kind of, I guess, depending on the hiatal configuration, whether it's like a V or a more circular hiatus, do you guys do enterolateral where once you start your posterior closure, get to the side and you do the right and left cruise and then the kind of some of the arch? Is anyone doing a pure anterior stitch which is completely opposite the posterior crural closure?
Almost always do a left anterolateral stitch.
Right. I mean, the point I'm trying to get at is I just wanted to ask you guys before I made that point is that most recurrences happen anteriorly also because we mostly do a posterior crural repair, whether you use a mesh or not. Number one. Number two, posteriorly you obviously have crura, even though the right crura is always more terrible than the left one. You have something to suture to, whereas anteriorly you don't really have a whole lot to suture to. So it's inherently weak, is what I'm trying to say. So I think that's some of the reason why most recurrences happen anteriorly as well.
I will say I put an anterior stitch, and not because I think it's like a strength stitch, but to cause a little bit of fibrosis, like with an ethibond suture. So thinking that may scar down a little bit.
And then maybe to answer a couple of questions, I do like a V-lock closure, not always, but for a big defect. But I take care to make sure that I'm not using the V-lock because I have excessive tension during my closure. If it's a tense closure, it just needs a relaxing incision, end of story. But the V-lock does tell me I use a 6-inch, and I don't close beyond that. Once I'm out of suture, I'm done with posterior closure then, and I don't want to angulate too much, so I'm moving on to something different, either anterior medial or anterior lateral, depending on the strength of my crural pillars.
There was another question about I guess when do we use a G tube, if at all, during large paras?
Almost never.
Never.
Almost never. I think in the last 6 years, once when a patient who had a recurrence, third time recurrence, said that his major complaint was inability to vomit and gas bloat, and it was a Hail Mary.
No.
Yeah, I don't think it's that PEXI, using the G tube as a PEXI is an old school thought process, I think. The only other thing I would say is I've had a couple patients that have, after really large paraesophageals, have like a gastric ileus, and they call it like a gastric outlet obstruction. I've had 2 or 3 patients that on a post-op CT scan, or they present with symptoms of abdominal pain. They're really uncomfortable. You think they're peritonitic, get a CT scan, and it looks like there's a gastric outlet obstruction. Sometimes that's just a really bad gastric ileus, and if you do like a venting G, they actually get better. I've had 2 or 3 over the 10 years of those, but it's pretty rare.
Yeah, same. And I remember the old school days where we used to, anybody who had an intrathoracic stomach got a G tube. And I don't know if it helped, but it definitely did hurt a lot. So the patients really hurt from the G tubes. And to Caitlin's point, I mean, I just placed one a couple of months ago because this lady was at, I don't know, 10 TID of oxy for her chronic pains. I was like, well, and she had a massive hernia, like she's going to have gastroparesis. So I put a G tube in her, which she pulled out. So it didn't make any difference. But yeah, very rarely now.
I was going to say, I'll do it. I've done it twice for other reasons. Again, old frail patients, BMI of 16, who I was pretty sure they were not going to be able to swallow very well afterward, fully intrathoracic stomach. So I agree. I think it's kind of gone by the wayside, but I do think it has its advantages, both as venting and possible feeding, rather than putting them on TPN for a few days as well.
Yeah, I agree with Jonathan. I mean, I've seen a couple patients, they come to see in the office from a SNF or from a nursing home, and they're frail, and you can kind of just tell by looking at them that they're not going to eat very well even after you fix their hernia. So I think PEG in those instances is beneficial.
But I think we're saying PEG for those reasons, not because you think you're going to hold the stomach down like a PEXI.
Right.
Correct.
Second that. Exactly the point.
And then how much time we have? I guess last question, Ivy.
Yeah, there's
How
just
many-
one question. Yeah, go ahead.
No, go ahead.
No. Okay. Well, I think we answered most of them. There's one additional question asking about the use of air seal and what you guys drop your pressures to when you close the hiatus.
I mean, I'm
Sorry,
notoriously
go
the
ahead.
one. Oh, sorry. I was going to
No,
say
no.
I'm notoriously the one that cautions against air seal. And I always say this with a caveat because it just come out. I had very little training on it. Started using air seal early on in my practice, and would put the pressure to 15 with the air seal. And I had 6 tension pneumos requiring emergent tubes in the PACU in 6 months. And I could not figure out what was going on because I never had, you can have pleural rhines, you don't get tension pneumos. And I was like, you know what? The only thing I've changed was air seal. I've stopped using air seal. I've never put in a tube again for a tension pneumo. So I am very cautious with it. That being said, that was my experience. I know people use it well, maybe lower pressures, and possibly I wasn't trained appropriately, but that was my cautionary tale.
I second that, Caitlin, for the air seal. The only 2 times I've had to put a catheter or a tube in was when I used air seal on these patients with pretty significant tension capnothoraces. I think there's no added benefit to an air seal for this operation. There's an added cost and there's potential harm.
Yeah,
Yeah, I think
been partners with Caitlin. She taught me not to use AirSeal. So
He was there when that all was happening. So
but in terms of the part about the pneumoperitoneum, so I'm 100% robotic. So I typically will work anywhere from 8 to 10 millimeters of mercury for the whole case, unless there's any problems with visualization. So I'm not lowering the pressure down any lower when I close the hiatus, because I'm doing the whole case at those pressures.
Yeah, I think the amount of subacute emphysema and CO2 retention with the AirSeal is also significantly higher. I case observed at Priya's institution when I transitioned to robotic surgery, and they were like, we don't use AirSeal because another specialty has it. And I was like, great. So I've never used it. And the times that like it's been accidentally turned on now that we have the DV5, it's just caused a lot of trouble and headache for us. So I think the panelists, most of us agree on that. Yeah. Okay.
I'll be contrarian. I disagree. I really like AirSeal. I don't use it as system port, and we don't have DV5 at our institution, but I don't use it as port. I just use the purple cap. And I've had no tension pneumos. I've had one crepitus case without AirSeal, none with. I keep the pressures at 8 to 10. I've actually really like AirSeal. I think it has done a good job of keeping the smoke out of the way in slightly higher BMI patients, closer to 35 with being able to keep a pressure at 8. And I do it for pretty much all my other cases too. But I'm contrarian, sorry.
That's the beauty of this webinar is we each have our own sort of niches and things that we like to do for our cases. So it's 9 o'clock. It was great to see all of you. We hope everyone who attended enjoyed the session. There will be a recording that will be uploaded within the next week if you missed any part of this. Have a great night, everybody.
Thanks. Good night, everyone.
Thanks, everyone.
See you all in Vegas.
Thank you for organizing.